This is the last of a three-part series on pulse oximetry. It will focus on clinical considerations, including interpretation of results. I have no conflicts of interest to disclose. I have no conflicts of interest to disclose. This section will look at limitations of pulse oximetry as well as interpretation of results. At least some of the problems leading to difficulty in obtaining a value on a pulse oximeter are related to the difficulties imposed by signal-to-noise ratio. Factors contributing to this can be a weak signal, such as occurs with poor perfusion, or a large amount of noise, such as occurs with bright lights or motion. The pulse oximeter may interpret the noise as the true signal, or alternatively, the noise may obscure the true signal. This illustration appeared in part 1 of this series. It shows the tissues that must be traversed by the light from the transmitter to the receiver. The problem is that the illustration is misleading. In reality, the determination of saturation is made based on less than 5% of the total signal. Accordingly, the problem with poor perfusion is a weak signal. Stated another way, the absorption due to pulsatile arterial flow typically accounts for 1 to 5% of the total signal. Accordingly, it should be no surprise that the device may have trouble determining values in the presence of poor perfusion, that is, decreased pulse wave amplitude. As the quality of the devices has improved, they are more likely to be able to make a determination, but perfusion is still a potential limitation. The literature also contains some articles suggesting that a pulse oximeter may be more likely to obtain a reading if the probe is placed on the forehead, using reflectance instead of transmission technology, or ear. Be aware, however, that some companies make unique probes for the ear and specifically recommend against using probes designed for the finger on the ear. One more factor which is not exactly a problem with inadequate perfusion would be anything that causes venous pulsations. While not specifically related to arterial perfusion, the presence of a large amplitude venous wave, such as occurs either with tricuspid regurgitation or Canon A waves in the presence of complete heart block, may result in spurious values if the oximeter interprets the venous wave as a normal arterial pulsation. Lights and electric cautery are the most likely causes of interference in the OR setting. This represents a problem with a large amount of noise which may obscure the signal. Each type of light has a different emission spectrum. Interference from lighting occurs if ambient light reaches the sensor. Some pulse oximeters measure ambient light and subtract that reading from the signal measured during light transmission. In any event, covering the probe, especially with a dark cloth or the foil packaging from an alcohol swab, generally eliminates the problem. Classically, fluorescent light is described as being the most likely to interfere with pulse oximetry readings. That's probably due to the fact that commonly used fluorescent lights have a wavelength peak near the wavelength used by the pulse oximeter. Perhaps the most interesting example of light interference is an experience I personally had about 3 years ago. After seeing my patient, a child, in the holding area, I returned to the OR to see if the resident was ready for the child. In fact, the resident had already left the room to get the patient, so I was the only person in the room. When I entered the room, the pulse oximeter probe was lying on the OR table, and the OR light was also shining on the OR table. The interesting thing was that the pulse oximeter was displaying a plethysmograph and a saturation of greater than 90%, even though the probe was not on a patient. More recently, interference has been reported with the use of the Medtronic Stealth Station navigation system. As previously noted, simply covering the probe almost always eliminates the interference. Motion artifact is one of the leading causes of false alarms from pulse oximeters. Remember Aesop's fable about the boy who cried wolf? Alarm fatigue is a real problem. Think about your experience in the operating room. While you probably don't ignore a pulse oximeter alarm, can you honestly say you respond to every alarm from an infusion pump as aggressively? Imagine you're caring for a patient in the ICU or the PACU. The tendency will clearly be to ignore, or at least respond slowly, to an alarm if 3 times out of 4 it is false. The problem with motion artifact is that the motion creates noise, which makes it more difficult for the oximeter to recognize the signal. Although manufacturers have worked to develop motion-resistant technologies and algorithms to reject motion artifact, the most commonly used method of minimizing false alarms is averaging the data over a longer period of time. This slide looks at the impact of data averaging on detecting apnea in premature infants based on pulse oximetry. The first panel shows frequent episodes of desaturation associated with apnea when the data are averaged over 2 seconds. Clinically, it's evident that all the episodes are rapidly detected. In the second panel, in which the data are averaged over 8 seconds, all the apneic episodes are detected and an appropriate alarm is generated. Clinically, there is a slight delay in the alarm. Averaging over too long a period of time may result in loss of data. In the last panel, in which the data are averaged over 16 seconds, apnea still occurs, but no alarm is generated. This study reports the results of pulse oximetry alarms for post-op patients in the PACU. The default averaging was 3 seconds. Using a computer-generated assessment, when averaging was extended to 10 seconds, false alarms were reduced by 50%. If the data were averaged over 42 seconds, the alarm rate was reduced by an additional 82%, but almost 10% of the episodes of hypoxemia would not have been detected. Another study reported similar results. Extending averaging times to 10 to 12 seconds resulted in fewer false alarms, but also decreased the ability to detect true episodes of hypoxemia. This graph demonstrates that anemia is associated with decreased accuracy of pulse oximetry in the presence of poor oxygenation, although the exact mechanism is debated. The same article reports that the lower the hemoglobin, the less accurate the pulse oximeter, and also that the worse the oxygenation, the less accurate the pulse oximeter. Note 2 things. 1. The research was done nearly 30 years ago, and instrumentation has undoubtedly improved over time. 2. The value reported by the pulse oximeter was spuriously low. More recent studies have essentially duplicated the direction of the bias, if not its magnitude. Now let's consider some clinical limitations of pulse oximetry. If you refer to my presentation on assessing oxygenation, you will see details of how I believe that the ratio of the partial pressure of oxygen in arterial blood to the partial pressure of oxygen in the alveolus, the AA ratio, can be used to determine how well the lungs are working as organs of oxygen exchange. Also, the determination of arterial oxygen content is critical to the assessment of oxygen delivery, which is the primary responsibility of the cardiorespiratory system. Based on the oxyhemoglobin dissociation curve, any arterial PO2 greater than 90 millimeters of mercury is going to result in a saturation of 95% or more. If the patient is receiving supplemental oxygen, this severely limits the ability to use pulse oximetry to assess how well the lungs are functioning as organs of oxygen exchange. This graph shows the effect of changes in oxygenation as assessed by the partial pressure of oxygen in arterial blood and pulse oximetry following endobronchial intubation. Note that despite the fact that arterial PO2 decreases from 400 to 100, the saturation is still 100% as indicated by the pulse oximeter. This is indicative of the fact that, in the presence of increased inspired oxygen concentrations, the pulse oximeter is a poor indicator of how well the lungs are functioning as organs of oxygen exchange. Note that even though the saturation remains unchanged at 100%, the AA ratio has decreased from 60% to 15%. That being said, if inspired oxygen concentrations are kept relatively low, perhaps 30%, the pulse oximeter can be useful in detecting significant changes in lung function. With regard to oxygen delivery, since the pulse oximeter does not provide any direct information relating to either the hemoglobin concentration or the cardiac output, it is of limited usefulness in assessing oxygen delivery. Prior to the widespread acceptance of the accuracy of capnometry in spontaneously breathing, unintubated patients, attempts were made to use pulse oximetry as an indicator of respiratory depression. It was advocated for patients who were undergoing procedural sedation from nurses or physicians without anesthesia experience, for example, during colonoscopy. It was also advocated to monitor patients receiving neuraxial opioids on the floor. In order to have a saturation of less than 90% while breathing 30% oxygen, the PaCO2 will need to be about 90. When was the last time you administered an FiO2 of less than 0.3 to a patient who required supplemental oxygen? Remember also that since each liter per minute of oxygen by nasal cannula increases FiO2 by about 3%, 3 liters per minute corresponds to about 30% oxygen. Again, when administering oxygen by nasal cannula, when was the last time you used a flow rate of less than 3 liters per minute? Remember, if you want more details on these calculations, review the appendix, which appears after the photograph, which normally indicates the end of my presentations. Several additional points must be made. First, an AA ratio of 0.75 is at the lower limits of normal. If the AA ratio is higher, the hypercarbia needs to be more severe in order to have the saturation be less than 90%. Second, the reality is that several changes occur with hypercarbia, for example, enhanced hypoxic pulmonary vasoconstriction, which may actually increase the AA ratio, thereby increasing the degree of hypercarbia necessary to have an oxygen saturation of less than 90%. All of this can be summarized by noting that the pulse oximeter is a poor monitor of hypercarbia and respiratory depression. Because under normal circumstances, only a very small portion of light from the LEDs actually reaches the sensor, and because pulse oximetry measures changes associated with pulsation, the decreased amplitude of the pulse oximeter wave may compromise the accuracy of the pulse oximeter or may make it difficult for the device to detect a pulse at all. The more severe the anemia or the hypoxemia, the less accurate the measurement. Ambient light reaching the sensor compromises the ability of the sensor to determine changes in light due to arterial pulsations. Some devices measure ambient light and adjust the readings accordingly. Averaging values over a longer period of time minimizes the number of false alarms, but if the interval is too long, the device may miss some episodes of desaturation. The ratio of the partial pressure of oxygen in the arterial blood to the partial pressure of oxygen in the alveolus is the best way to determine how well the lungs are functioning as organs of oxygen exchange. The shape of the oxyhemoglobin dissociation curve means that an arterial PO2 of 100 is indistinguishable from an arterial PO2 of 600 using pulse oximetry. In the absence of knowledge about the hemoglobin concentration or the cardiac output, a pulse oximeter does not help assess oxygen delivery. For patients with low normal values for the AA ratio who are receiving 30% oxygen, the PCO2 needs to be 90 millimeters of mercury before the oxygen saturation decreases to 90%. For that reason, pulse oximetry is a poor monitor to detect apnea. For patients with better oxygenation and those receiving more than 30% oxygen, the PCO2 needs to be even higher to result in saturations less than 90%. The math associated with these calculations are included as an appendix at the end of this presentation. The next few slides go into the math to show why PCO2 has to be so high in order to produce desaturation as detected by a pulse oximeter. Although there are a lot of shortcuts for calculating the partial pressure of oxygen in the alveolus, this is the quote correct unquote formula. Here are the calculations using room air with a respiratory quotient of 0.8 and an arterial partial pressure of carbon dioxide of 40. Note that the resulting alveolar PO2 is 102. Pause the presentation to make sure you understand the calculations. Here are the same calculations for 30% oxygen. Note that the alveolar PO2 has increased from 102 to 167. As previously described, the best way to assess how the lung is functioning as an organ of oxygen exchange is to calculate the ratio between the partial pressure of oxygen in arterial blood and in the alveolus. Remember that from a prior slide that on room air, the alveolar PO2 is about 102. Accordingly, an AA ratio of 0.75, the lower limit of normal, would correspond to an arterial PO2 of 76 on room air. If you use the rule of thumb that a normal, age-based arterial PO2 is 105 minus the age divided by 3, even a 90-year-old should have an arterial PO2 of 76, which corresponds to a saturation of approximately 95%. For the purposes of the following calculations, I am going to use an AA ratio of 0.75. In this equation, assuming an AA ratio of 0.75, I have calculated that the alveolar PO2 must be 80 for the arterial PO2 to be 60. The question is, how effective will a pulse oximeter be in detecting hypoventilation? The calculation on this slide indicates that an arterial CO2 must be 54 before the arterial PO2 falls to 60, that is, before the saturation is 90%. Pause the slide at this point and make sure that you're comfortable with the calculations. This slide simply repeats the calculations with 30% oxygen. Note that in this circumstance, the PCO2 will be more than 90 before the saturation is 90%. Keep in mind that the higher the AA ratio, the higher the PCO2 must be to result in desaturation. For example, making no changes in these calculations other than to assume the AA ratio is 0.9 results in the determination that a PCO2 of 117 is necessary to achieve a saturation of 90%. That having been said, in my opinion, it's more realistic to use an AA ratio of 0.75. Sedation will likely result in a decrease in tidal volume with consequent atelectasis, producing an increase in intrapulmonary shunt fraction and thereby a decrease in the AA ratio. The bottom line is that the pulse oximeter is a poor monitor to detect hypoventilation.